Good afternoon, good morning, good evening to all of you who have joined us from all over the world. This is part two of a two-part webinar presenting the findings of the National Pandemic Pulse run by faculty and researchers from across the Johns Hopkins Bloomberg School of Public Health. It's our pleasure to be hosted by our hosts from the Center for Global Health at the Bloomberg School of Public Health, and we thank the Johnson & Johnson Foundation for their generous support of this exciting work. My name is Alan Labreek. I am a professor here at the Bloomberg School of Public Health in the Department of International Health, and I serve as the Associate Chair for Research for the Department of International Health. Today, we are going to be presenting the second part of findings from a US representative survey that was conducted in late December of 2020, looking at the impact of COVID-19 within the US across a large representative population. This is part of a suite of work that's being undertaken by researchers here at the university under the umbrella of a project called COVID Inequities. Our website is covidinequities.org, where you're welcome to visit to see the recording of Wednesday's lecture if you were not able to join us for that webinar, and other exciting and pertinent resources that are collated at that, including the findings of the Rich Life Project and the HIT COVID non-pharmaceutical intervention tracker for COVID-19 interventions around the globe. This is the second of two pulses, and the first pulse results are available online at on the covidinequities.org website, and that recording is also available at that location. As part of this series, we've been also developing policy briefs that we will continue to generate based on the modules that are contained within this national survey. And you see here two examples that focus on the high levels of stigma and shame that we found in the September survey conducted in early September of 2020. So we hope that these policy briefs, accompanied by peer-reviewed manuscripts that we're pushing into preprint, as well as the peer-reviewed literature, will help inform and guide policymakers within the US and globally as we consider the implications of managing this pandemic over the coming months. So it's my pleasure today to introduce a distinguished panel of colleagues, as I did on Wednesday, featuring the work that we are focusing on vaccine acceptance, food insecurity, economic distress, and mental health during the pandemic. Whereas on Wednesday, we focused on aspects of pandemic fatigue, ranging from changes in risk perceptions, pandemic anger, trust in science and scientific institutions during the COVID-19 pandemic. I thought I would start by giving you a few quick takeaways from the Wednesday's presentations. I apologize for those of you who were at Wednesday's lecture. This will serve as a bit of a recap. But for those of you who are joining us fresh, if you don't get a chance to watch the webinar recording, a few things that we presented to the public. One was the persistence of racial, ethnic, and socioeconomic inequities that persist. As we move from non-pharmacologic control to vaccine-based preventions, these important gaps remain to be addressed. We've also found that overall perceptions of risk increased broadly between September and December of last year, illustrating that as a public health community, we have had success in communicating risk effectively, but there are still differentials that younger Americans and white Americans reporting lower perceptions of risk across all essential activities. And this data also reflects the strong political polarization associated with perceptions of COVID-19 risk. We've seen continued disruptions in pregnancy care due to COVID-19, with data suggesting high levels of anxiety, depression, and food insecurity among pregnant women. We must study how these might affect health outcomes both for the mother and the fetus. We've documented in this December survey that pandemic anger is extremely high and resistance to public health measures remains strong at about a fourth of the population, demonstrating strong resistance and anger to public health measures. Political affiliation and loss of job security or employment are major drivers of this frustration. We also have shockingly low confidence in science and scientific institutions focused in a few groups, particularly African Americans and Native American populations, with, again, stark differentials along political lines. There were low levels of overall trust in 2020 political leadership, some religious groups and social media, but higher trust in one of the key institutions of the medical establishment, and that is primary care physicians. We see a lot of heterogeneity in the locus of trust by age, race, ethnicity, and politics, which suggests the importance of audience segmentation as we message around pandemic prevention mechanisms. And as I mentioned earlier, the experience to US pregnant women has been seriously disrupted during the pandemic, with reductions seen in antenatal care, with 10 to 22% reporting changes to birth plans, with a 19% change to C-sections from vaginal delivery. So this high level of distress and food insecurity compared to non-pregnant women is certainly an area of great concern. So today our presenters will be Dr. Dustin Gibson, Dr. Jeff Edwards, Dr. Julia Wolfson, and Madhu Jalan, who will be presenting different modules from the December Pandemic Pulse. So it's our pleasure to have these fantastic presenters working with us today. So I want to just quickly say a few words, given the focus of this survey on highlighting some of the inequities that have been exacerbated by the pandemic, uncovering deep-seated inequities that persisted long before the beginning of COVID-19. As this data from earlier in 2020 showed, the disproportionate impact that COVID-19 mortality has had on people of color within the US, namely African American and Hispanic or Latino communities, as well as American Indians and Alaskan natives. In some of the news from that hit the popular media, this was highlighted as we see here the disproportionate impact on mortality that African Americans and Native Americans experienced around the country, here highlighting 74% mortality, 74% mortality in African Americans versus the 46% of the city population that they represent. Whereas in Arizona, we saw Native Americans making up only 5% of the population, yet accounting for 18% of the deaths. The same inequity persists in Latinos as well in other parts of the country. So it's important for us to acknowledge as part of this series that at the root of it, racism kills. And whether this is through force, deprivation, or discrimination, racism is a fundamental cause of disease and a familiar root of the racial health inequities that we face. As we enter into a time of vaccine rollout, we see that the impact of the disparities we saw in morbidity and mortality has persisted in the distribution and allocation of vaccines. And in the media over the past week, we've seen a lot of stories that highlight this inequity, where Black Americans are being immunized at a much lower rate than their white counterparts across the country. This data that is being released by certain states so far, not all states have released disaggregated data by race, that is supported, as we see in this report, by the Kaiser Family Foundation, where I'll have you focus on the dark blue bars, which represent the proportion of African Americans vaccinated in these states, in contrast to the caseload and the population load shown in the other blue bars. So we can see that we certainly have miles to go before we have achieved equity in the proportion of our population exposed to COVID-19 vaccinations. So there are numerous factors that contribute to increased adverse outcomes that are balanced across racial and ethnic lines. And you can see these on your screen, ranging from discrimination all the way to income and wealth gaps and housing conditions. So these conditions both exacerbate the risk of exposure as well as the risks of other underlying conditions, with exacerbating the reduced likelihood of timely testing, care seeking, and care receipt. It's critical that we make it very clear at the outset of our webinar today that we are using race here as a socio-political framework, and certainly not a biologic one, to examine the underlying systemic racism and its consequent inequities. The same is true for ethnicity. So there are clear limitations to the degree of nuance that one can extract in a large nationally representative survey, but this hopefully adds more data to all of our collective actions going forward as we tackle this pandemic. Let me now pass the baton over to my colleague, Dr. Gibson, to lead you through the methodology of the survey.
So thanks, Alan, for putting this work in together, putting it all together. I'll spend the next few slides briefly going over the rationale and our methodology before I turn it over to each of our four speakers to go over some of their highlights and key findings. With that said, there are numerous trackers out there that monitor downstream outcomes like symptoms and deaths throughout the pandemic, and most recently, the number of vaccines that have been delivered by jurisdiction. But very few trackers exist that measure upstream indicators of the pandemic, like risk perceptions, preventative behaviors, vaccine attitudes, etc., all of which are helpful to guide public health action and policy. As Dr. Lebrique mentioned, our objective is to quickly capture the pulse of the nation through multiple cross-sectional surveys over time. The survey contains questions from existing COVID surveys, as well as those identified by team members here at Hopkins that appeared to be lacking in the literature. The final questionnaire was reviewed by team members at the School of Medicine and the School of Public Health. And our survey contains really a core set of COVID-19 questions that we will ask in each round to monitor temporal changes, such as pregnancy, risk factors, etc., risk perceptions, as well as the ability to add in new trending topics. For example, in September, we had a module on school reopening, and in December, we've included a module on pandemic anger. We conducted this first round of surveys in September, and at today's seminar, we will discuss findings for our second survey, which took about a week to complete and was concluded just prior to Christmas. We plan on conducting an additional 4 rounds of surveys spaced 2 months apart, and hope to have future webinars where everyone will be able to come together and we can disseminate these findings. I would like to highlight that our large sample size, nearly 9,000 complete surveys, makes our work unique from others in that it allows us sufficient statistical power to examine some of these health inequities across a range of subpopulations. In terms of methodology, we contracted Dynata, which is one of the largest first-party data platforms in the United States, to deliver our survey. In short, Dynana sent email requests to a targeted but random sample in order to create a nationally representative survey on gender, age, race, census division, and income. The survey was an online survey programmed onto an enterprise version of SurveyMonkey, and participants were eligible if they were 18 years or older, a US resident, and of course provided electronic consent. These exciting results that we'll be sharing with you today come from our second survey, which again went from December 15th through December 23rd. Our most recent survey included a set of socio-demographic questions and 9 COVID-related modules. Wednesday's seminar focused on the modules on the left, such as risk perceptions, antenatal care, which were included in the first round, as well as new modules on pandemic anger and trust in science. And for today's seminar, we will discuss the modules on the right, the COVID-19 testing cascade, vaccine willingness, economic distress and mental health, issues with food insecurity. I won't spend too much time on this slide other than to point out that you can see that our quota sampling approach in the red produced similar results to those from the census in the blue. And those estimates were similar for both gender, race, ethnicity, age, and the census division. And then the pie chart on the right shows a fairly representative distribution in income, with about 25% of our sample reporting an income of less than $25,000. So that's our sample. And I just wanted to highlight that before we go into our key findings, I would like to clarify that for the most part, these analyses today are preliminary and often univariate analyses. We thought it was more important to get these results out as soon as possible rather than conducting more elaborate analyses. So just please keep that in mind. And with that, I'd like to pass over to my colleague, Jeffrey Edwards, to talk about the COVID-19 testing cascade.
Thank you, Dr. Gibson. So as he mentioned, I'll be talking about the testing cascade as well as touching on the economic distress module. And so thinking about the testing access for Americans in 2020, December 2020, we looked at the testing cascade by race in terms of how they accessed testing, the test positivity rates, looking at that by age, race, age, income, and political party affiliation, as well as the hospitalization rates by race. As we can see, there's actually, this is an overall broad overview of the testing cascade. So looking at the left of those who wanted or needed a test, going on to then those who were able to get testing, and those who tested positive, and those who were hospitalized. As you can imagine, each of the, as you go down the cascade, there's a subset of the prior group. And as you can notice, there's similar trends across race when you're looking at the general proportions from each step of the cascade. However, as we zoom in, we do see some inequities when we're looking at those who tested positive and those who were hospitalized out of those who were able to receive testing. And what we noticed, again, in this cohort, we're looking at those who ever tested positive, for COVID-19. So this is not necessarily looking at a snapshot in time of the test positivity rates, but rather within this cohort, those who had tested positive for COVID at any time within the past year. And as you can see, there are much higher rates within our Native American respondents of people who were testing positive out of those who received a COVID-19 test compared to the counterparts, white, Black, Latinx, and Asian. Something that we want to note, though, as we mentioned in our Wednesday webinar, is that the sample size, although generally pretty large, when we go down to our Native American respondents still made up a smaller proportion of the overall sample size. And so we included the N for each of these values just to give you an idea of where that stands within the overall proportion of the data. When we're looking at further results for test positivity, we note that this is the baseline average for ever test positivity, right around 29%. But then as we look, especially, what it stands out especially is that the Native American within our respondents had a 60% positivity rate, over twice of what the average was. So now as we go into looking at test positivity by race or by age, we also notice that there are higher rates of test positivity amongst younger respondents, which correlates with the what we were seeing portrayed in the media as well as by public health officials, that this last wave, especially in the winter, made up of younger individuals who were testing positive for COVID-19. And as you can see, both by the N as well as by the percentage, you have a marked increase in that 18 to 24 range, as well as 18 through 44 compared to the older individuals. And so this is just to highlight those three groups that are showing higher test positivity rates. And then what we also noticed was that there were trends in the percentage of asymptomatic cases that tracked across these different age groups. So if you look at the far left and the far right, we can see that the 18 to 24-year-olds and then individuals over 65 both had higher percentage of asymptomatic positive testing. And so when we think about this, we think about some of the different behaviors that could have likely produced this result. One being that younger individuals are more likely to be asymptomatic with COVID-19, whereas on the far right, you have probably a higher baseline test probability, in that there will be more individuals who are over the age of 65 who might be receiving testing on behalf of contact tracing or other public health measures used to accurately measure the amount of COVID-19 cases. And so that's why I believe that we have these results that show these higher percentages of asymptomatic cases in the youngest and oldest respondents. Additionally, we also ran these analyses, as Dr. Gibson mentioned, very preliminarily on education level and by income. And we actually saw relatively even ever test positivity rates based off of education level on the left, as well as by income level on the right, which gives us some optimism that the testing access, when we look at race, education level, and income, has improved and that it's equalized over time, which was something that was an emphasis in terms of public health officials and policymakers to try to level that playing field and reduce any disparities that were happening with regards to access to testing. And then lastly, looking at this, we see higher ever hospitalization rates in Black, Asian, and Native American respondents. And so I will include those three groups and just direct your attention to those three groups that have 57, 59, and 65% hospitalization rates out of those who tested positive in our smaller cohort. And we included the ends there as well. And note on the right, only 12 and 15 respondents for Asian and Native American respondents, but even still, you can see the contrast to the overall sample in terms of those higher hospitalization rates. And so as a summary for the testing data, we noticed that there are improvements in availability of testing across different demographic factors, but that is mostly noted by the increased access to testing across race, education, income level that has leveled out over time. But we also still notice that there are higher rates of ever test positivity and hospitalization in Native American respondents, a community that was hit particularly hard by COVID-19. But even noting with the caveat, this is with the smaller sample size, and higher ever test positivity rates in the younger respondents, which corresponds to what the narratives that have been mentioned by public health officials. Now I'm going to touch on the economic impact of COVID-19 on Americans in this December 2020 survey, and mostly to focus on the job loss or income loss by race and income, as well as the economic impact on routine health-seeking behavior by race. And so as we all know, COVID-19 has had severe economic impacts on many Americans. And in our survey, over 20% responded that they either lost their job or 50% of their income, which is a massive source of economic distress. Further, when we asked how many were either concerned or very concerned about covering their basic household costs, close to 50% reported that they were concerned about being able to cover their basic household costs, which can cause additional psychological distress in addition to that economic distress. When we break this down by race, we note that this has continued to exacerbate already existing disparities. So we note that Black, Latino, and Native American respondents were more likely to face these severe economic impacts. And here, especially looking at the Native American respondents, you see the cohort average being around 21% that were facing that, but over 35% of Native American respondents reporting that they lost their job or half of their income. We also noticed that these disparities held across income groups. So looking at the proportion of those reporting that they lost their job or half of their income, those in the two lowest income groups that we reported, less than $20,000 and between $20,000 and $39,000, had much higher rates of reporting that they also lost their job or half of their income, which were already on the lower income brackets to begin with. And then when we think about how these economic impacts can translate across different decision-making behaviors or different domains, we start to ask how does this impact people's ability to receive routine medical care? And so as you can see on this slide, we asked people if they skipped either out on a prescription or treatment, testing, or follow-up appointment for routine medical care. This is not related to COVID-19. And as you can see, for Black and Native American respondents across the board, almost, you see this increased proportion of those who skipped those routine medical care appointments due to the economic hardship, which follows that these were the groups that were most hardly hit economically by COVID-19. Interestingly, those differences carried across most routine health-seeking behaviors, as you can see in the seeking care and seeking specialist categories, but it did not follow as strongly for dental care and vision care. So summarizing these economic impacts, you continue to see these major inequities of COVID-19 by race and income. And particularly, we saw that Black, Hispanic, and American Indian or Native American respondents had higher rates of severe economic distress caused by the pandemic. And the low-income respondents were also more likely to report these severe economic distress. And all these results highlight that the COVID-19 pandemic has served to exacerbate previously existing inequities, and that these groups that were already facing various health inequities, as well as these inequities in social determinants of health, have continued to face these during the pandemic. And even as these questions demonstrated, some of them have faced even worse outcomes compared to their other counterparts. And so when we think about how does this impact our policy moving forward, something that our team discussed is the ability to change stimulus packages or develop economic recovery policies that take into account these differential impacts of COVID-19 on racial minorities as well as low-income individuals. And thank you. With that, I will pass along to next presenter, Dr. Gibson.
Hello again. Sorry about that. Let's see. All right. There we go. So today I'll be talking about COVID-19 vaccine perceptions and beliefs. This module was asked both in our September and December survey rounds. I'll focus on the willingness to receive a COVID-19 vaccine and how that estimate has changed over time and how it differs by key subpopulations. For those who indicated being unwilling to receive a COVID-19 vaccine, we asked why not, and we will examine these reasons. And then lastly, we'll look at the different places where people get their vaccine information, so vaccine sources. And I'd just like to comment that much of the news has been on supply side issues, such as not having enough vaccine supply, to the logistics of running a mass vaccination campaign. There has been some discussion on the demand side issue with similar studies to this, and we hope that these slides and presentation further this conversation. So here the graph on the right shows the percent of the population willing to receive a COVID-19 vaccine when made publicly available. And overall, we can see an 11% increase from September to December, or about 59% to about 70%. And I think context is important here. When we surveyed participants in September, there were, I believe, 6 or 7 vaccines under phase 3 clinical trials. And in December, by the time of our survey, there were at least 2, if not 3, vaccines that had just been authorized for use. And so this was more in the news. So I just wanted to highlight differences that may also help explain increase in COVID willingness. This slide, the graph on the right shows COVID-19 vaccine willingness by race and by survey month, with September in red and December in blue. I've also plotted the red and blue lines to show survey averages, which were from the previous slide. And several key points. We saw that 11% increase, and it appears from September to December that this increase is strictly or mostly due to gains in the white population. And that second, that COVID willingness among Blacks remained fairly stagnant at around 50% from September to December, with some gains in the Hispanic population. But lastly, and perhaps really most importantly, is if we focus on the December blue bars between the white and Blacks, we can see a 23% difference in COVID-19 vaccine willingness. So the white population 23% higher than Blacks to receive a COVID-19 vaccine. And I think this is important in the context of cities and preventing disease transmission. Here are 2 maps from the New York Times. This was a few years ago, where they were commenting on how segregated cities were. The map up top is Baltimore, and below is Philadelphia. And with it, it shows the census tract by race composition with Blacks in blue. And I don't know if it's red or green for white individuals. I'm colorblind. But it's showing the racial composition of census tracts by color. And if we really think about it, what Dr. Fauci says is that we need roughly 75% of immunity to block COVID transmission. It's not necessarily at a national level or a state level or even at the city level in Baltimore. It's really at the community level, and we've seen this with measles outbreaks in Northwest and communities there, and at amusement parks. So if we look in West Baltimore in the top, where the neighborhoods are predominantly Black and willingness to receive COVID-19 vaccine is at 50%, we could think that there may be greater difficulty in controlling COVID transmission there as compared to the whiter neighborhoods of Baltimore, where communities are 95% white, and stopping the transmission there may be easier. In addition to race, we also looked at COVID-19 vaccine willingness by gender. Again, using the same colors for September, red, and December in blue, we can see that males are consistently more willing to receive a COVID-19 vaccine than females over time. And in fact, that women have underperformed the national averages of our surveys by about 10% for both rounds of the survey. So males substantially more willing to receive a COVID-19 vaccine than women. Given our large sample size of about 8,500 complete surveys, we thought it might be interesting to explore the effect or interaction of gender and race on COVID-19 vaccine willingness. And this is just for our our December data. And so with the exception of the Asians on the far right of the graph, we consistently see a 15 to about an 18% gender gap difference between females and males among white, Black, and Hispanic populations, with Black females showing the lowest willingness to receive a COVID-19 vaccine at about 45, 46%. Since our survey was nationally representative using these 9 census divisions, we thought it might be worth looking to see if there were any geographic differences in COVID-19 vaccine willingness. And for most of the country, it's about a 5% difference in willingness, so no minor changes. The lowest region, the East South Central Division, which consists of Kentucky, Tennessee, Alabama, and Mississippi, was at about 62%, or about 12% lower than the Pacific West Coast, around 74%. This was a slide I put in last minute just based on our Wednesday presentation, where our doctoral student, Prativa Baral, gave a really fascinating graph and presented population estimates for trust in different institutions. And I was really surprised to learn that about 20% of the US population, or 1 in 5 people, either disagreed or strongly disagreed with the following statement: "I trust scientists and scientific institutions to do what is right for my family and I." So I just thought, sort of also as a way to check the quality of our data, that I thought it might be interesting to see how this finding was associated with the COVID-19 vaccine willingness. And as expected, it maps near perfectly and is almost perfectly associated with the highest levels of COVID-19 willingness in those who trust scientists, approaching 90%, and the lowest levels of those who strongly disagree, approaching 20-25%. So it's a bit expected. It makes sense, but for me, when I do these large surveys, it's always helpful to have some data quality controls to make sure your data is telling you have trust in your data. And then, so those were sort of the main, there are many other subpopulations that we did examine and had significant differences in COVID-19 willingness, but due to time, I'm unable to share them here. So we looked at age, political party, et cetera. These were all significant. But with my remaining time, I'd just now like to focus or to present findings on reasons for not being willing to receive a COVID vaccine. So specifically, we had about 2,500 people who were either unwilling or extremely unwilling to take a COVID-19 vaccine. And we asked them to select which of these reasons listed here in the table were applicable. In short, vaccine concerns were the top 2 choices, with 56% having concerns about the vaccine safety and 47% having concerns about long-term health consequences associated with the vaccine. Another one point how we have adapted the survey was that in September, we did not include the response willing to get the vaccine but don't want to be one of the first. That was discovered after looking through all the other options. So for this survey, we included it as a sort of a priori option, and we found that about one out of 4 people listed this as a reason for not taking the COVID. So these people may be, although not, may contribute to the achieving herd immunity later in the stages. They just sort of want to wait a month or two to see, how the vaccine rolls out. Are there any unexpected adverse events, et cetera, but, may ultimately are leaning towards taking that. And then we did look at these reasons, by different subgroups here. I just chose to present race since it's one of the main themes of this webinar. And we didn't really find any differences amongst white, Black, or Hispanic respondents. There was really no differences in the top 3 concerns or even the top 5. Where there were some differences was around the vaccine is not necessary. So this was the largest difference, highlighted in yellow, where about 8% of Blacks thought the vaccine is unnecessary, compared to about 19% in whites. And just of note, this was a select all that apply question. So the average number of reasons per respondent was 2.2. And just before wrapping up, we did ask respondents who their most trusted source for vaccination information was. And overall here, by far, CDC and family physicians were most trusted. And among the, looking at this by white, Black, and Hispanic, that trend also appears to hold. So CDC and family physicians being most trusted. There were some minor, very little differences in the other sources, with the exception of maybe family and social media, which had higher reported levels in African Americans as compared to our national averages. But overall, not that many differences. And so I think to just the takeaway slide, I think although it's promising that the COVID-19 vaccine willingness has increased from 59% in September to 70% in December, it's alarming that the gains in willingness have occurred predominantly in the white population, with no gains in Black or other minority populations. So as of December, there is a 23% gap in COVID willingness between Blacks and whites, and about a 15% gender gap between females and males. In addition to these subgroup differences in willingness to receive the vaccine, respondents provided a variety of reasons for being unwilling to receive the vaccine, driven by various sources of vaccine information and misinformation. And so I think, although we have, highly effective and safe vaccines out there, this compounds the challenge of delivering these vaccines at a population level in order to achieve herd immunity levels needed to prevent or slow transmission. So with that, I think I'll pass it over to, is it Juliana?
Yep. Thank you, Dr. Gibson. And certainly some really provocative and thought-provoking findings with regards to vaccine equity and distribution planning. Over to you, Dr. Wolfson.
Okay, thanks so much. Thanks so much, Dr. Greek and Dr. Gibson. See if I can make the slides go ahead. There we go. So I'm going to be presenting the results from our food insecurity module, which was newly added in the December wave. I'm going to present food security status by race, age, employment status, income, and political party affiliation, and then also present some data about access to free food over the last 30 days and access to social safety net benefits. There's been a lot of policies and programs put in place throughout the pandemic to get food into the hands of struggling households. So it's an important to see who has been able to access them and any disparities therein. Okay, so I want to spend a couple of moments to just talk about how we measured food security in this survey. We measured food security with the USDA Household Food Security Module, a 6-item short form, and this is a validated and widely used questionnaire to measure household food security status. We asked about food security over the last 30 days. And on the right-hand side of your screen, you can see the 6 questions that make up that food security module. We asked respondents to how much they agreed or how often the food that they bought didn't last and they didn't have money to get more, how often they couldn't afford to eat balanced meals. And then we asked them whether or not 3 statements were true. In the last 30 days, did you ever cut the size of your meals or skip meals because there wasn't enough money for food? And if they said yes, they were asked how often that happened. A response of 3 days or more in the last 30 days is coded as an affirmative response. We asked, in the last 30 days, did you ever eat less than you felt you should because there wasn't enough money for food? And were you ever hungry but didn't eat because there wasn't enough money for food? So responses to those 6 questions get coded, and an affirmative response is coded as a point, right? And then get categorized into 3 different food security statuses. Food secure, which is really characterized by consistent access to adequate, nutritious food. You have enough food, you have enough money for food, you're not really worried about being able to feed yourself and your family. And then the 2 statuses that together get characterized as being food insecure, having low food security, which is a score of 2 to 4 on that 6-question scale, in which case you're worried about not having enough food to eat. You may be reducing the quality of your diet, but you're not disrupting the quantity of food that you're eating. You're not eating less or going hungry. Whereas very low food security is a score of 5 to 6, and that's really characterized by not only worrying about not having enough food to eat, but also not eating enough, skipping meals, or in some cases going hungry for the whole day because you can't afford enough food to eat. And in our survey in December 2020, 33% of Americans were food insecure. And again, that's the orange and red categories combined. Now, 33% of households in the United States experiencing food insecurity is incredibly high by historical standards. Showing here is data from the USDA about national food insecurity rates over about the last 20 years. And you can see that it mostly hovers around 11 to 12%, with a jump up during the Great Recession at the end of 2007 through 2009. Up to around 15%-ish. Food insecurity then hovers around that level for a few years and slowly begins to decline prior to the start of the pandemic. The dotted blue line is that very low food security status, and you can see that is very low, is much lower by about 10%. In our data, it's about 16%. And here, even at the peak of the recession, it's just under 6%. These levels of food insecurity historically mask some serious disparities based on race. So here is the same data from the USDA over the last 20 years, broken out by race. The green line now is that overall line. And then you can see the orange and blue lines at the top, which represent Black and Hispanic households, Black in blue and Hispanic in orange. And you can see just how much higher their rates of food insecurity are compared to white households. we see those same disparities in our data as well. So here I'm showing again at the top of this bar that those overall numbers. So now you see food secure in green, low food security in orange, and very low food security in red, and those will be the way they're characterized throughout. And then that 33% combining low and very low. That average, that national average, is going to be shown in that vertical dotted line throughout as well. So you see overall 33% are food insecure, with lower rates among the non-Hispanic white group and about twice as high rates of food insecurity in Black and Hispanic groups compared to white. Nearly half of African American households, 47.8%, are food insecure, and 45.9% of Hispanics are food insecure compared to 25.4% of whites. So really, really stark race disparities here. We also see a trend based on age as well. So here we see food security status based on age, with a clear trend that younger Americans are experiencing higher rates of food insecurity. When we look at employment and loss of employment during COVID, using some of those measures that Dr. Edwards presented earlier, we can see that, people who are full-time employed and employed part-time are experiencing food insecurity to some degree, but really what we see is quite startlingly high rates of food insecurity among this group of people, about 21% in our sample, who lost their job or more than half of their income due to COVID-19. 70% of them are food insecure, and nearly half, 45%, have very low food insecurity. And again, that is where you are experiencing hunger. You are skipping meals and not getting enough to eat because of lack of money for food. We see an income gradient here as well, which one would expect because food insecurity is characterized by lack of sufficient resources for food. And so we see, lower income Americans experiencing higher rates of food insecurity than their higher income counterparts. Food insecurity is a bipartisan problem. So while we see some differences based on political party affiliation, really, all political parties, people who identify with all political parties are experiencing food insecurity. Okay, so I want to turn to, where people are accessing free meals and groceries. As I said, there have been a number of policies and programs put into place throughout the pandemic to get free food into the hands of households who need it. Sorry about that. We asked people in the last 30 days, did you or anyone in your household get free groceries or a free meal? And what we find is about 20% of our sample did receive free groceries or a free meal. And more of them were in that food insecure group. Nearly half of people with very low food security did receive free groceries or a free meal. When we look at where people who got free meals received them, the frequent sources were food pantries or food banks and school programs, which tracks with national data where there's been a lot of coverage about the emergency food system or food pantries or food banks being really overrun with demand for food during the pandemic. And school programs really mobilizing and creating innovative solutions to getting food into the hands of families whose children would have been receiving meals at school when school's in person. So finally, we asked about receipt of public benefits during the last 30 days. And we asked about 4 programs specifically. the Special Supplemental Program for Women, Infants, and Children, or WIC, which is a federal program that provides money for food to pregnant and lactating women and children aged 0 to 5 years old. We asked about SNAP, or the Supplemental Nutrition Assistance Program, which provides low-income households with money for food. And then we also asked about the Temporary Assistance for Needy Families program, another federal program that provides extra money to low-income households and Social Security insurance benefits. What I want to draw your attention to here is that in our sample, nearly 1 in 5 Americans did receive SNAP benefits in the last 30 days. And by comparison, that's high. In 2019, 1 in 9 Americans received SNAP benefits. SNAP has mobilized very quickly during the pandemic to get to enroll more people as they lost jobs and needed benefits. I think enrollment grew by 23% compared to 2019 in the latest data available. The other thing I want to draw your attention to here is that 72% of our sample received no benefits at all from any of these 4 sources, which speaks to perhaps some unmet needs in the sample. So when we look at receipt of benefits by food security status, we see, that food insecure people are getting the bulk of the benefits, which is good. It's getting into the hands of people who need them. But 40% approximately of Americans with low food security and very low food security did not receive any benefits at all. And that indicates a real unmet need, that people who perhaps are eligible for benefits are not receiving them. So just to review what these initial analyses are indicating, food insecurity is historically high, more than double what we saw even at the height of the Great Recession, and is associated with very stark disparities. The COVID-19 pandemic has exacerbated existing disparities that have long been established around food insecurity and really heightened them. Black and Hispanic Americans have higher rates of food insecurity compared to white Americans, and younger and lower income Americans are more likely to be food insecure. Loss of employment or income due to COVID-19 is associated with particularly high rates of food insecurity, about 70%, which is deeply concerning and requires a very strong policy response. And 1 in 5 Americans receive SNAP benefits, but many food insecure Americans are not receiving any social safety net benefits, and could possibly mitigate some of the food insecurity that they are experiencing. So more to come, stay tuned on that. But for the time being, I'll turn it over to Madhu Jalan. Thank you.
Thank you, Dr. Wolfson. Really some phenomenal data, and I think enough to give us all pause about this major issue that's affecting the American people. With that, let me hand it over to Madhu to then build on that with a view on mental health. Dr. Jalan. Sorry, you're muted.
I figured, yeah. So, mental health section of our analysis has been added as a new module in phase 2 of the survey. So we know that the pandemic has caused havoc in people's lives. So mortality rates, social isolation, economic challenges, and uncertainties around employment, finance, and economy will likely continue well beyond 2020. And as you can see in this article by the World Health Organization, it points out that COVID-19 has disrupted mental health services the world over, I believe in 93% of the countries, though the demand for these services is continuing to increase. So for our analysis, in December 2020, we used the scientifically validated PHQ-4 questionnaire, which measures anxiety and depression through a set of 4 questions. The results are measured across a 4-point Likert scale, not at all, several days, more than half the days, and nearly every day. There are 2 questions around anxiety and 2 around depression. So if the sum of the scores on the 2 questions in each category is 3 or more, then it suggests clinical significance for that category. So for example, if for depression, if the person's score on the 2 questions together is 5, then it suggests that the person exhibits clinically significant levels of depression. Psychological distress is measured by summing up the responses across the 4 questions in both categories, and is measured as normal if the sum is between 0 and 2, mild if it's between 3 and 5, moderate if it's between 6 and 8, and severe for a total of 9 to 12. These cutoffs are useful to keep in mind as the rest of the analysis will continue to use these thresholds. So to compare pre and post-pandemic psychological distress, we looked at the overall numbers in our survey from December 2020 in comparison to the HINT survey from Q1 of 2019. The Health Information Trends Survey, or the HINT survey in short, is an annually nationally representative survey that is conducted by the National Cancer Institute, and it also uses the PHQ-4 scale. On comparison, we see that there is a 87% increase in psychological distress between the 2 time periods. Though the fact that there is an increase in stress between the 2 time periods is perhaps not surprising, but the magnitude is large. So drilling down into our December 2020 survey, we see that overall 47.7% of the population report some level of distress, with 12% reporting severe levels of distress, as can be seen by the red section on top here. In the lower 2 bars, we find that over 20% of the people exhibited significant levels of both anxiety as well as depression. Stratifying psychological distress by income levels, we find that the lower levels of income are associated with greater levels of psychological distress. This is particularly high in groups with less than income of $40,000, where 55% exhibit distress in the income group $20,000 to $39,000, and almost 60% exhibit distress in the income group over under $20,000, I'm sorry. In comparison, the group with income of over 70,000, we see 43% experience distress. You can also see that the severity is high in lower income groups at close to 16% for those in the $20,000 to $39,000 income category, and 17% for the lower than $20,000 category. Now, stratifying by race, the levels of stress are at 55% for African Americans, 67% for American Indians, as compared to 44% for whites. Let me caveat this by saying that the sample size of the American Indian category is too small to allow for further analysis. When we look at the severity levels, it is lowest for the whites at 12% and highest for Latinos at 17%. So moving beyond demographics, we looked at mental health associations with socioeconomic indicators such as job loss, insurance, and the use of medical care, as well as food security. Again, this number may not be surprising, but the distress amongst those that lost their job is 78% greater than those that did not lose their job. But looking at the severe stress in these two categories, it is more than 2 times for those that lost their job. Similar to the previous slide, comparing those with insurance and without insurance, we see 62% greater levels of stress amongst those without insurance. When we look at severity, we see that those without insurance are at almost 18% in comparison to 11% for those that have insurance. We asked 2 questions around delaying care. One was, in the past month, have you delayed getting medical care visits? This includes dental, physical, or mental health. And the second was, in the past month, have you avoided getting a medical prescription refilled because you didn't want to leave your house due to COVID-19? You can see that the results here are quite staggering, with 72% experiencing distress in the delayed medical care category and 87% in the delayed refilling medical prescriptions category. The severity levels, which is the red bars again, for delaying healthcare is at 22%, and for those that are delaying medical prescriptions due to the pandemic is at 30%. We looked at associations between food security and mental stress. The calculation for the food security is the same as what Dr. Wolfson presented in the last section. Over 80% of those with very food low security experience distress, and this is 2.5 times higher than those with food security. When we look at severity levels, it is at 17% for those with low food security and 29% for those with very low food security. We also look at associations between trusting the accuracy of news with regards to COVID-19 from various media sources, such as broadcast media, cable news, print news, and the social media. And those that trusted social media saw 40% greater stress than those that trusted traditional news media sources. Unfortunately, this potentially suggests that the vast number of conspiracy theories and misinformation on social media is adversely impacting our mental health. So as this analysis has shown, the magnitude of those experiencing mental distress during the pandemic is staggering. Mental distress is strongly associated with socioeconomic insecurities, delays in accessing medical care, food insecurities, and relying on social media for news. But even prior to the pandemic, mental health has been unaffordable and inaccessible for many people due to a shortage of mental health providers, the high price of care, and a lack of comprehensive insurance coverage for these mental health services. As we struggle to contain COVID-19, it is very likely that the pandemic will have long-term adverse consequences on mental health. To fight such an outcome, we need policies that would help build human resource capacity, focus on special populations, and invest more in providing coverage for these mental health services. Now pass it on to Dr. Agarwal.
Great. So thank you, Madhu, for that presentation. And Alan, will you just advance the slides? Thank you. We've had so far a great discussion on the results, but we certainly welcome any additional questions that the attendees might have. And thank you very much for your patience as we work through these results. So I will quickly summarize, but also please feel free to raise your hand with a question or type in more questions in the Q&A box. So what we see is for vaccine acceptance, that there are significant variations by region with greater vaccine acceptance amongst those who trust scientists. And a part of the hesitancy comes from conspiracy theories, but the largest proportion of individuals or respondents express concerns about safety, especially around long-term concerns. And I think that's an area for us to really focus in our efforts on as well. We also see the lowest vaccine acceptance amongst African-American respondents. And we must know that Black, Hispanic, and Native American people are about 14 times more likely to be hospitalized and 3 times more likely to die from COVID compared to white people. But these are the populations that also have the lowest vaccine acceptance. And it really speaks to the history of mistrust that has been sown from medical experimentations and unequal institutions amongst these populations. In testing access, we see comparable testing across racial groups, which is great. However, as expected, higher hospitalization amongst Black, Asian, and Native American respondents. For economic distress, Black and Hispanic respondents have higher rates of economic distress and loss of over 50% of their income, or a large proportion of them have a loss of over 50% of their income. And in food security, it is at a historical high, with about a third of American households experiencing food insecurity, especially amongst those who have lost their jobs due to COVID-19, and among Black and Hispanic respondents. Social safety net benefits are not reaching a large percentage of the at-risk population. And finally, given all of this, not surprisingly, we see the highest level of anxiety, depression, and distress amongst Black, Hispanic, and American Native respondents. So I think, and I hope that you will see from these data, as we see, that in the context of the pandemic, we're not all in the same boat. For some people, the boat has the biggest leaks, and this is exacerbating inequalities and inequities. And I can speak to the limitations of our data and to some of the methodological deficiencies of our approach. But what I think we can conclusively state is that those are unlikely to change the significant disparities that the data highlight. We certainly anticipated seeing this as we conducted the study, but having the hard numbers to speak to these inequities has been upsetting for all of us. And I hope that through this work, we're able to bring more light to it. We've had some great suggestions for additional analysis, and we are very open to looking at those, and we appreciate everyone's input. So please keep these ideas coming. We appreciate that. And also, I think there has been requests to make this survey more widely available so it can be replicated in other places. Please feel free to email us. Our contact information is on the last slide. Alan, if you advance the slide. And there are also other manuscripts that show a little more disaggregation in these data that, and we welcome any sort of collaboration and discussion around this work.
Thank you, Dr. Agarwal, and thanks again to all of these fantastic presenters today. I think I can't sum it up any better than your last phrase, that this has been a source of great distress and concern for all of us who have been involved as researchers in this survey. And just to hear it in the media is one thing, to see it unfolding in the communities around us is another, but then to see it affirmed in this national robust survey data is yet another reconfirmation of what we know to be true. And I think it's really a call to action for all of us, for policymakers, for those of us working on the ground in communities, and those of us conducting research, to continue to address this, not just during the pandemic, but as we recover from the pandemic going forward, learning about ways that we can address some of these inequities in our society and improve outcomes for all Americans and around the globe where such inequities persist. We want to thank everyone for joining. We had a really phenomenal attendance, and this will be all available in recording on covidinequities.org. And if you are a member of the media or press and you would like to dive deeper into the findings, please reach out to us or to the School of Public Health for more information. Stay tuned for the Pulse number 3 that will be going out in the coming weeks, and we hope to host another series like this one in the very near future. Are there any other questions that have emerged that we need to maybe address, or with that, I think we can render people a few minutes back to the half hour that's coming to a close. And Smisha or Dustin, anything?
No, thank you everyone for your time, and we can give you back 15 minutes of your lives.
All right.
Thank you for your Friday time too, especially if you're overseas and it's dinner time or even bedtime now. Thanks for spending your Friday night with us.